Hello and welcome to this very special edition of Live and Ticking on the topic of menopause and the heart in partnership with See Her Thrive. I'm Fearghal McKinney, head of BHF Northern Ireland. Today is World Menopause Day and this year's theme is cardiovascular health. So we've teamed up with See Her Thrive, an organisation dedicated to menstrual health, menopause awareness, gender equity and women's well-being, to bring you an event that highlights the importance of talking openly about the menopause and women's cardiac health. Our first speaker today is founder and CEO of See Her Thrive, Clare Knox. We'll also be joined by Carolyn Hodge, who experienced a heart attack while going through the menopause. Finally, we'll hear from Dr. Kirsty Roberts, who will talk us through how the menopause and the cardiovascular system interlinked and her research into the circulatory mechanisms of the menopausal hot flush. The BHF is a cardiovascular research charity. In this event, we're recognising World Menopause Day and its focus on cardiovascular health. You can submit questions to all our speakers via the Q&A function throughout the talks. If we don't have time to answer your question today or your question is beyond our speaker's expertise, we'll signpost you to the appropriate resource. You can also join our Health Unlocked community forum for support. This forum provides a safe space to discuss living with any heart or circulatory diseases. Finally, before we hear from our speakers, I'd like to ask you a quick poll question. How would you rate your understanding of menopause and the heart? I'll give you a little moment just to answer that question. Now, I'm delighted to introduce our first speaker today, CEO of See Her Thrive, Clare Knox. Over to you, Clare.
Thank you so much, Fearghal, and it's a real pleasure to be here today and to be part of this really, really important webinar. So thank you so much for joining everyone and for being here. I'm just going to share my screen with you. So if you bear with me 1 second, hopefully you should all be able to see that. Yes, I'm seeing some nods. So as Fearghal said, we are See Her Thrive and we are on a mission to make sure that female-related health issues are normalised, understood and supported in every single workplace. And so on World Menopause Day, we thought it was a really good opportunity to raise awareness of something that doesn't get much attention, and that's women's cardiovascular health. So it's really great to be with you today talking about this. And we wanted to set the scene first of all, because our menopause education is so poor, isn't it? I'm just thinking back to my kind of menstrual health education at school, and it was pretty horrendous thinking about it. I didn't learn about menopause. I didn't learn about hormones or anything like that. And so let's plug some of those gaps first of all and just zoom out and look at what's actually happening. What is the menopause and what's going on in our body? And menopause really marks the end of our reproductive life cycle. And the time leading up to menopause, which is 365 days after our last menstrual period, is where we can typically see symptoms start to arise. And that's called perimenopause. And what happens is our hormone levels, so progesterone, estrogen though mainly, and testosterone start to decline. And while they're in decline, they're also fluctuating. And so the hormone receptors we have all over our body, from the tips of our head down to the tips of our toes, can respond in various different ways. And that's why we see a whole host of different symptoms. And it's a very individual journey. I'm sure people who've joined today who are perimenopausal or going through menopause will understand what I'm talking about. But we can all experience very different symptoms. Some people will have severe symptoms, which can be debilitating. Some people will have mild to no symptoms and just breeze through. But this transition, this period of transition can last for decades, you know, for some people. And so it's really important that we're aware of it, that we talk about it, that we are prepared for it. And I think something else that's important to recognise is that menopause can happen at any point in our reproductive life for various different reasons. So some people might have an oophorectomy, that's removal of the ovaries, and will be in surgical menopause. There are lots of different health conditions like endometriosis, premenstrual dysphoric disorder, where people might be in chemical menopause to treat an underlying health condition. And we have conditions like premature ovarian insufficiency, which can plunge people into menopause at a very, very young age. So we're really, really passionate about making sure that, you know, we think about menopause as a diverse range of experiences and different journeys. And so what are some of the symptoms that we experience or that we can experience? And as I said, it's different for all of us. It's a very individual thing. Some people will experience physical symptoms, so hot flushes, night sweats, it changes to their menstrual cycle and their periods, palpitations. You know, we're talking about the heart and cardiovascular health, and palpitations is something that is very, very common. Some people will experience psychological and emotional symptoms, and it's thought that, you know, a lot of people, or it's known that a lot of people will see an impact on their mental health. So things like anxiety and depression, low mood, feeling overwhelmed and out of control, or losing interest, you know, feeling this sense of disinterest and loss of joy is really, really common. And then we have cognitive symptoms. So there is stuff happening in the brain. You know, we need estrogen to be able to perform our executive functioning skills. And so when we see those levels decline and fluctuate, we can experience things like brain fog, difficulty concentrating, forgetfulness. I don't know about you, but going out of the room, coming back in, forgetting what I went for, and forgetting names and things like that, which can be really frightening when it's happening, because sometimes, you know, you wonder if you've got early onset dementia. So all of these symptoms can present differently. They can change over time. It might be a cocktail of all three different categories. But we're here to talk about the heart, and I think we'll just focus on that for a moment. Estrogen is really important to protect our heart and our cardiovascular health. And I'm sure Dr. Kirsty is going to talk about this in more detail, so this is a bit of a whistle-stop tour. But when our estrogen levels start to decline, our risk of a heart attack and cardiovascular ill health, if you like, increases. And so it's great that we're here today to find out, you know, what we can do to look after ourselves and protect our heart. And really pay attention to that. And I thought, because we are focused on the workplace and looking at how we can make sure everyone is supported at work, I would just share some highlights about, you know, how menopause can impact people at work, because that's really, really important. And there is some fairly fresh data that was released last week, I think it was, from the CIPD, which found that, you know, despite progress being made, we are still seeing a lot of challenges when it comes to menopause in the workplace. And a lot of people are struggling with those psychological symptoms and those cognitive symptoms that are having a real impact. And I think what really breaks my heart is the thought of, around 1 in 6 people in this particular survey had considered leaving work. And we know that around 1 in 10 women are leaving the workforce because of a lack of support, a lack of awareness, and the difficulties they're having in managing menopause symptoms. So really, really great that we're here, that we're talking about this. And I hope that gives us a bit of a, foundation to build on. And I will, at this point, hand over to Dr. Kirsty.
So, Claire, almost right. Next on our list is Carolyn Hodge, who's going to share her experience of the menopause and heart disease. Interviewing Carolyn is Yana Thuraduro from the Research Engagement Team here at the BHF. Thank you so much, Claire. And now it's over to Carolyn and Yana.
Hello. Thanks, Fearghal, and welcome, Carolyn. Thank you so much for coming on the call today and sharing your story with us. It's such an important story to tell. But before we get started, shall we just dive in with a bit about yourself, your family, your job, your hobbies?
Okay. I'm Carolyn Hodge. I'm now 62 years old. But when I was 54, I had a heart attack while going through the menopause. I'm married to Ian. We've been married for 42 years. We have 2 sons, Matthew and Alex, and I have 4 grandchildren as well. So I'm a retired hairdresser. I also played in a band with my sister and brother-in-law, and voluntarily used to teach aerobics class at the school that my boys used to go to. So
Wonderful.
quite active.
Yeah, absolutely. It sounds like a very full life, lovely life. So when did you start the menopause and what were your symptoms like?
So I started the menopause at 52. I didn't do too badly during the day with the hot sweats, but they were very bad at night. I suffered from anxiety, and all the usual things, tearful, just generally feeling quite unwell.
Yeah. And when your heart attack happened, how far through the menopause were you? Can you take us back to that day?
I was 2 years in. Do you want me to tell you what happened on the actual day?
If you
would. I was 2 years in. I'd been to see my GP 3 times because I was having palpitations and chest pain, and they just kept telling me that I was suffering from anxiety and I needed to go home and learn to relax. So on the day before I had my heart attack, I was feeling quite unwell. I went to the gym in the morning. I booked myself a facial in the afternoon to try and calm everything down, because it did feel like everything was going at a rapid rate of knots. I had a facial in the afternoon. In the evening, my sister and brother-in-law came and I was very hot and sweaty. I didn't sleep much that night. I got up the following morning, on the Saturday morning, and I was just making a cup of tea for me and Ian, and I just felt this tremendous squeezing sensation at the top of my back, which actually knocked me off my feet. And then I was very sick and dizzy. And at that point, my husband phoned an ambulance.
Yeah. And when you got taken to hospital, what happened next?
So they took me to Wythenshawe Hospital, which is the Northwest Heart, the place where people go with heart problems. They took me straight through for an angioplasty. But even then, the consultant was very dismissive, and whatever had blocked my heart had gone through, because they'd treated me at home and they'd given me aspirin and other things. And he said to me, well, it doesn't look like you've had a heart attack. You may be able to go home later. So at that point, I felt like I'd wasted everyone's time and that we shouldn't have called an ambulance. But anyway, when I got onto the ward, the diagnostics consultant, who was really good, said, no, I'm not happy with this. He did a scan, which proved that I had actually had a heart attack.
Yeah. Oh, well, it's horrible, any situation like that where you feel like you've wasted people's time. You shouldn't have felt like that.
I really did feel like I'd wasted his time, because he was, I mean, I'm not going to name any names, but he was very dismissive, very dismissive.
Yeah, a heart attack is an emergency, and anybody who has symptoms like that should call 999.
Yeah.
So when you were treated, what was your recovery process like? Did you get to go home that day?
No, I was in hospital for 5 days, wired up, with the pads on, wired up to a machine. I went home after 5 days with my bag of numerous tablets, having never had any medication before. And then after 4 weeks, I started my cardiac rehab at our local hospital, which was really good, really good.
Yeah, how did you find that?
I found that really helpful, and it was just really good, and no one was dismissive there. Everyone was very supportive, and yeah, I had 16 sessions, and then they just build you back up, and they teach you what to worry about and what not to worry about, what things to be aware of, and things like, and how to carry on with your life. Really, I did have quite a bit of counselling after.
Oh, did you?
Yeah. I did, because you just have this enormous fear that it's going to happen again.
Yeah, and obviously you were quite fit before doing your exercise classes and stuff.
I was really fit and well. So I had to start again from the beginning and build it all up again gradually.
Yeah, and you said it was at these cardiac rehab sessions that you discovered that heart attacks are linked to the menopause.
It was the cardiac nurse, Tim, who was really good. And I'd gone in one day, and they wouldn't actually let me do the session because my blood pressure and heart rate was far too high. So he took me aside and we were chatting, and he told me that, I mean, this is almost 8 years ago, and he said that they did think that there could be a link between the menopause and women having heart attacks and heart disease, which I didn't have a clue about. I had no idea that that was a thing.
And I think it's something that people still don't really understand that widely now, about how the heart and the cardiovascular system is affected by the menopause.
They don't, because none of my friends were aware of it. All my friends of a similar age were so shocked, and they had no idea that it was a possibility.
Well, we're trying to change that. And you said that a family member. What did your family member say when you had a heart attack? When you had your heart attack?
That was my dad. Who was in his 70s. And my sister went to tell him what had happened to me and that I'd had a heart attack, and his comment was, women don't have heart attacks. It definitely is seen as a middle-aged man thing.
Absolutely, and it's a massive misconception. It's, the man clutching his chest whilst eating a fry-up who has a heart attack.
Exactly, and it's not like that at all. Well, it wasn't for me anyway.
There are so many women who have heart attacks and need to be treated for them. And what sort of place are you in now? Because obviously you said this is 8 years ago.
I'm good. I mean, I am good. I take a lot of medication, all preventative, 3 times a day, 1 lot in the morning, 1 at tea time, and more before I go to bed. All preventative, aspirin, stuff to keep my cholesterol down, blood pressure medication, another one to keep my heart rate down, because my heart, since I had my heart attack, my heart beats far too fast. So I take medication to keep it at a good level. But I am really well. I am really well. Yeah.
Yeah. You get back in the gym?
Back in the gym. Try and go about 3 times a week. And I like to walk and I like to swim. I have to be aware. I'm not allowed to let my heart rate go over 142 for any length of time. So you just have to be, it affects you for the rest of your life. They call this a life-changing event, and it really is a life-changing event. But you can live a really good life, but you just have to be aware and just be careful.
Yeah, no, I think that's very... And take your tablets, of course. And just lastly, what advice would you give to somebody who might be going through a similar experience? Maybe they're going through the menopause and are experiencing have been through a heart attack, possibly a stroke. What would you say to them?
Don't let the doctor dismiss you. Insist on having some tests. Insist on them either doing an ECG or just some tests, just to make sure that your heart and your arteries are doing okay, and that you haven't got heart disease or any kind of heart issue. Don't let them tell you that it's just anxiety.
Yeah, no, absolutely. Well, thank you so much for sharing your story on here. We really, really do appreciate it. And I think it's back over to you, Fearghal.
Thank you. Thank you.
Thanks very much, Jana and Carolyn. And just to add, BHF really appreciates the fact that people like you are willing to share your story so openly and to help others as well. And I'm delighted with that idea of you back in the game. So finally, we're very excited to hear from BHF Daphne Jackson Trust Postdoctoral Research Fellow, Dr. Kirsty Roberts. Over to you, Kirsty.
Thank you very much, Fearghal, and good afternoon, everyone. I'm just going to share some slides, which I'm hoping you'll all be able to see. So I'm Kirsty Roberts. I'm a postdoctoral research fellow sponsored by the BHF. And this afternoon, I'm just going to run through a few things to do with my research. Essentially, menopause and the cardiovascular system. My focus of my research is looking at the mechanisms underpinning menopausal hot flushes. I'm going to talk a bit about the goals of that research. But firstly, I'm just going to give you a whistle-stop tour of my career to date, which is quite varied. So I started off as a medical secretary at the local district general hospital, where I worked for 10 years. The final 2 years of my job there, I studied a sports therapy degree at Stafford University, where I developed a bit of a bug for research and looked at the effects of kinesiotape on blood flow with a view to its rehabilitation properties and healing. After I graduated, I worked at the National Football Centre, St George's Park over at Burton-on-Trent for a little under a year as pitchside manager, providing medical cover for events and courses. And then I was extremely fortunate to get an opportunity for PhD studies at Liverpool John Moores University under the supervision of Dr. David Lowe. And my project there was to look at the effects of tea on vascular function. After I graduated my PhD, I had some time out for family reasons, and those are my 2 cheeky monkeys, which keep me on my toes away from work. And then in terms of a return to a research career, I've been extremely fortunate to get the support of the Daphne Jackson Trust with a BHF-funded postdoctoral research programme that is part-time and is focusing on menopausal hot flushes, and that's back at Liverpool John Moores University. So a quick overview really of menopause and the cardiovascular system. As Claire's nicely set the scene, menopause is associated with these huge fluctuations in estrogen. And you can see here that premenopausal, we have a nice steady state of estrogen level within the body. And then we encounter these fluctuations, which cause a whole host of debilitating symptoms. Premenopause, estrogen is protective, and it helps us to maintain good cardiac function. And importantly, vascular health is optimal with good vasodilation peripherally and centrally. And it also helps us to control that circulating cholesterol, reducing the buildup of those fat deposits on vessel walls. Now, the menopause transition sees a huge increase in cardiovascular disease risk factors. We see weight gain, particularly centrally, and there are also further metabolic changes with regards to a worsening of glucose or blood sugar control, which can contribute towards the pre-diabetic state. There's an increase in systolic blood pressure throughout the menopause transition, which is caused by a stiffening of the arterial wall. And as I've already mentioned, there's that buildup of fatty plaques associated with cholesterol, because the vessels and just generally things just don't function as well. In premenopause, estrogen inhibits the progression of those fatty deposits. So as soon as that estrogen level declines, it sort of promotes this dysfunctional state, which is when we see this narrowing and this plaque formation. Now, importantly, lifestyle has a huge bearing really on how we can try and mitigate some of these risk factors during that menopause transition. So obviously, an obvious lifestyle factor is smoking, which, you know, as we all know, causes issues there. But I think importantly, physical activity and the role of a sedentary lifestyle also has a huge bearing on our vessel health. And diet feeds into that as well, in terms of those choices that people make, high fat, high sugar foods. Looking at this graph on the left, it shows brachial artery FMD, and it's a recent study. Now, FMD is a measure that we use in the lab, which provides a really good marker of overall vascular health. So it's a good one to use as a benchmark when we're undertaking research studies. And you can see quite clearly here on the left-hand side, in this premenopausal state, we have a really good flow-mediated dilation response. And you can see this gradual decline as we go through the menopause transition until we reach this late postmenopausal stage, where there's an almost 50% reduction in that artery response. So that is a good marker of an overall reduction in vascular health. Looking at the graph on the right, this decline you can see coincides with this decline in estrogen, which obviously clearly depicts the issues once we reach the end of menopause, and the fact of, you know, we have an average life expectancy now of almost mid-80s for females in the UK. So that's post-menopause period where you've got a decline in vascular health. It's a long time for females to be struggling with the effects of vascular dysfunction. Claire's already nicely touched on these debilitating menopausal symptoms, and I think it's again really important to highlight that they are wide-ranging, and some women do experience them a lot more than others. For example, you get some women who barely experience a hot flush, whereas others are completely floored by them. You know, they are life-changing for some women, and in particular, around 80% of women experience hot flushes for 5 years or more. That's a huge period of time to be struggling with those symptoms. And the main treatment for the hot flushes at present is hormone replacement therapy, or HRT, as we all know. It's important to remind everyone that HRT is not suitable for everyone, particularly females who've had a past history of breast cancer. Historic links with breast cancer in research papers a few years ago led to a poor uptake, and also I think, as the media has highlighted in the last couple of years, you know, that there are issues around supply and availability of women getting HRT. So really it highlights that there are few alternative treatments available for menopausal hot flushes, which is largely driven due to our lack of understanding regarding the mechanisms that underpin the menopausal hot flush. So hot flushes are thought to occur either as a result of disruptions to thermoregulation or control of core temperature, so a more central mechanism, particularly within the hypothalamus and the brain, or also thought to be a local mechanism, so driven in terms of alterations in skin blood flow and sweat glands. And this sort of fits with the idea that the key events of a hot flush occur at the skin. So we see the reddening, the flushing in the skin, and this sweating response. So this led to the research question of my postdoc, which is that, you know, are these local changes in the skin responsible for the hot flushes? Is it some sort of change in skin function or skin structure or responsiveness? So the aim of my research is to examine the function or responsiveness, as well as the structure of skin, blood vessels and sweat glands in pre and postmenopausal women. So in a parallel group design, 3 groups, I'm looking at a group of postmenopausal women who experience hot flushes, a group of women who are postmenopausal who don't experience hot flushes, and some might say they're very fortunate, and a group of premenopausal women who are a bit younger but healthy. So there's also the ability to compare aging between those 3 groups. It's important to note those groups as well. The women are not taking HRT or any hormone replacement as part of the treatment. The techniques I'm going to use, this is very simplified way of showing how we're going to test skin function or responsiveness using a technique called skin microdialysis. So essentially you can see here 3 membranes on the forearm. Each of these is about a hair's width, and they're inserted just beneath the forearm skin. And then on top of that will sit a capsule, and this capsule will house a laser Doppler probe, and this will measure the skin blood flow, and this capsule here will collect any moisture. So essentially helping us to examine the sweating response. Through these membranes, a drug will be infused or perfused, and then that Doppler probe there will be able to measure that response, that blood flow response to that drug. And 3 different drugs that we find naturally in the body will be used to provoke that response at gradually increasing doses. Skin structure will be examined via a skin punch biopsy, which some people may have encountered in a dermatology clinic. This will be performed under local anaesthetic and a 3mm core. As you can see here, that's its actual size versus a 1p piece. It's really small, but it allows us to, following processing, staining and so on, it allows us to be able to visualise the blood vessels seen here in green and sweat glands seen over here in green, so that we can compare skin structure across our participants. So this is quite a simplified model of what we're looking for. So in terms of skin function and responsiveness, we want to know, is there a difference in blood flow and sweat rate between those symptomatic and non-symptomatic females? And you can see here, for example, in this example graph, if this was the symptomatic, this red line was a symptomatic group, you could see that potentially as those doses of that drug increase, they're seeing a much greater response. They're sort of triggered, if you like, by those drugs, versus a group of non-symptomatic women. So there's possibly greater elevations in that skin blood flow and sweat rate. In terms of skin structure, again, across comparison between groups, we're looking to see whether, compared to the non-symptomatic group, we see the potential for an increased quantity of blood vessels and sweat glands per sample, and whether these are actually of greater size compared to that non-symptomatic group. So the research goals of doing this is really to improve our understanding of the mechanisms to ultimately help us to design the potential for future therapies. It's also important to ensure that we maintain patient and public awareness of the fact that we don't still fully understand the mechanisms behind the hot flush, which limit the options out there in terms of how we can try and help the women that do experience them. Lifestyle really needs looking at in terms of the potential for interventions. We know that exercise can help, exercise training can help women to cope with the hot flushes. They reduce the severity and the frequency. So can we develop some further interventions around lifestyle or exercise that can help women, particularly those that can't take the likes of HRT? So there's still a lot of work to be done around those. I think crucially, we need to make sure that menopause stays a topic of conversation, because without continued research into the causes of the hot flushes and potential treatments, you know, we're still not going to fully answer these questions that we have and how we can find the treatments available for some of these women, particularly the ones who aren't able to take HRT. So I think we need to keep it out there, keep it on everybody's agenda, and make sure that we continue funding good research to reach some of those answers. So just a little about the support I've received from the BHF to date during this postdoc. I like to think of a research career as a bit like a game of snakes and ladders. There's plenty of ups as you set out, but there's a lot of pitfalls or issues that arise along the way. Taking a break to have a family, you've made a bit of progress before, but then you sort of feel like you've fallen off the board completely or down the largest snake. So the BHF and the Daphne Jackson Trust really have given me a huge ladder, huge helping hand in terms of getting back on that research career pathway. And this is really through forging strong relationships with mentors, supervisors, with the BHF and the Daphne Jackson Trust themselves, to ensure that the research that we're doing is timely, it's needed, and that we have the right goals and the right aims at the end of it, and that these are realistic in terms of balancing that part-time postdoc that I'm doing, so that the research and everything else is nicely balanced. Importantly, there's a lot of support around personal development. So this is also around ensuring that you're looking after the person or the researcher, improving the wider skills, if you like, around communication, leadership, all those sorts of things, as well as the lab skills and developing new techniques to help answer some of those research questions. There's plenty of opportunities for collaboration and making sure that people are discussing ideas as to how we can drive that research forward, and thinking about the long-term application that we might need for funding, in terms of making sure that everything's there to help us further the research in that area. So with that, I'd just like to thank my supervisory team at Liverpool John Moores, and in particular the Daphne Jackson Trust, and of course a huge thanks to the BHF for their help so far and for inviting me to speak today. So thank you, Fearghal.
And a huge thank you to you too, Kirsty, for your presentation. We're now going to welcome back all our speakers for the Q&A sessions, and if you have any questions, and I see plenty of you have, for Clare, Carolyn or Kirsty, please continue to pop them in the Q&A box. Kirsty, you have touched on here HRT and some risks around cancer, but should menopausal women be given HRT to manage symptoms and reduce heart disease risk?
Thanks, Fearghal. I think really the answer is to really consider every option. You can go down the medication route. There's various sort of natural therapeutics, if you like, people can go down, but really the goal, what I would recommend is people go and speak to the GP. There's plenty of menopause specialists, well, GPs in particular, taking a real sort of interest in becoming menopause specialists now, and hospital care as well. So really, people need to go and have those conversations. Don't be scared of having those conversations. They need to be had, and women need to seek that right support. So if anyone's contemplating it, isn't sure, wants to know more, certainly go and speak to the health professionals.
Any reflections on that, Claire?
I would just echo what Kirsty has said. Yeah, there's, it's really important to speak to a doctor, because they will get your medical history, they'll understand any risk factors, and they'll be able to walk you through any potential risks and benefits and weigh that up and figure out, what the best treatment pathway is for you. And I'm sure, as a lot of us joining today will know, it can be a case of trial and error, and that is a whole other journey. So it's really important, I think, to partner with a healthcare provider to be with you on that journey.
Okay, Carolyn, any thoughts?
I just there's lots of alternatives to HRT, but I think you just have to do what's right for you, and when I was going to my GP, I didn't know there was such a thing as menopause specialists. I think that's probably a good idea to speak to somebody who is specially trained in that area. A lot of GPs don't know a lot about it.
I think that's right, Carolyn. And I think all I'd say on that one is some practices are a bit more proactive than others.
Yeah.
And if you don't feel that you've got enough support at your practice, I think people need to push for a referral to a consultant, to secondary care, and don't just give up, really.
Yeah.
Keep banging that drum. Yeah.
Don't accept no.
Yeah.
There's a second question in. I'm going through menopause, this questioner says, and could do with some support from work, but I'm nervous about having that conversation. Do you have any advice? Claire, maybe you want to kick off?
Yeah. So I think a really good place to start is to think about why you want to have that conversation. Is it because you want support? Is it because there's been a change perhaps in your performance? Have there been any kind of incidents at work that you want to talk about and address? So just being clear on kind of the reason why you want to have that conversation, and that will hopefully guide you to get the outcome you're looking for. If it's to get support because you're finding it difficult at work, what we often recommend is just spending some time thinking about what specific aspects of the job or your work environment are you finding difficult because of symptoms or because of how you're feeling, and make a list of those, write them down, and then think about, okay, so what would be supportive? What would be helpful for me when I'm feeling like this, when I'm struggling with X, Y, and Z? And that can give you a bit of a framework to go into a conversation. If that's going to be with your line manager, then you've got a very clear idea of the challenges and also the potential adjustments that might be helpful. It can also be really worthwhile doing a bit of research to find out what is available to you in terms of support. Do you have a menopause policy? Do you have access to things like flexible working? And just do your homework before you have that conversation. In most cases, I know it can be really, really daunting, and we don't talk about it every day. So it might, it does feel uncomfortable, but in most cases, we hear a lot of positive experiences when people do open up and they're met with support and understanding. And that, that can be transformative if you're in a really difficult place. So yeah, I hope that helps as a starting point.
It does, and both of you have addressed some of this issue about talking about what do you in your research, Kirsty, and you and Claire in the previous answer. This question wants to know, why do you think it's important to talk about the menopause openly?
Yeah, Kirsty, do you want to jump in?
I just think it's a very complex period of time for women, and it's associated with so many different elements, so many different symptoms that have a knock-on effect in terms of mental health versus physical health. And I think really we're in a society now where we're all trying to look out for one another, and I think it's a really difficult period of time, and I think it's good for people to understand where you're at and also be able to help. They might have some life experience of some of these things and they can input as well, or they might have seen something and they can signpost you to some help, or they might have seen an advert for something else. And I just think that the conversation needs to be had. There's a lot of unanswered questions around the menopause, and like I've alluded to, it's a huge period of time, the postmenopausal period, where people are still struggling with the fallout from that menopause transition. So I definitely think we need to maintain that awareness. Claire, do you have anything to add?
So for me, and just thinking about when I was a secondary school teacher and experiencing PMDD symptoms, which, it's not the same, but similar, the energy that you put into masking symptoms or how you're feeling, it's huge. It's like, it's absolutely exhausting to go into work and feel like you've got to put on a mask and just keep going, push through, keep smiling, keep performing, keep, bringing it. And at some point, the wheels come off, something has to give. And it's incredible. And we see it, when we do talks training and people feel like they can talk about it more openly. It's like that pressure valve has been released. You don't have to hide what you're going through and conceal it. And you can you can be authentic. If you're feeling rubbish, you can be open about that. And it's just, it makes things more manageable, because you're not trying to squash everything down and bottle it up. And we know that can have long-term impacts on our mental health and well-being. So that's why I think this is really, really important to talk about and be open about.
And maybe just touch on you, Carolyn, was your experience one of keeping it to yourself or opening up?
I think it's a woman thing. I don't think we say when we're not feeling well, and we just think we can just do everything and cover it up, and we just try and carry on. And that's when you start having real problems, like you say, mental health, physically, because it's just exhausting. Just exhausting, trying to keep everything going. And a lot of the time, at the age when women are going through the menopause, they've got teenage children as well. They've got elderly parents. They're working. So it's just a culmination of everything.
Okay, thank you all. Next question for you, Claire. How and why did you start, and why did you want to start See Her Thrive?
Oh, goodness me, the full backstory. So as I mentioned there briefly, I have a chronic hormonal condition called premenstrual dysphoric disorder, PMDD for short. And it means that every month before my period, I have this onslaught of symptoms that, for me, it manifests as fatigue, as depression. I can't concentrate. I have terrible brain fog. I lose interest in everything, my job, things I usually love, my husband. And I become a completely different version of myself. I'm cycle day 20 today, and I can feel, the clouds start to descend. So rewind 6, 7, 8 years ago now, goodness me, I can't remember. And I was a teacher, as I said, and being in a very, very structured, high pressured environment with no flexibility at all. I really struggled to manage at work, and did that thing, got onto Google and tried to find information and support. Things like, how do I talk to my manager? What support is available for PMDD at work? And there was nothing, absolutely nothing. And so that was the catalyst for a real change in direction. And I retrained and thought, well, I'm going to do what I can with what I have, and this needs to be on everyone's agenda. There are 1 in 20 people, females of reproductive age, who are living with this, not to mention other menstrual conditions, endometriosis, polycystic ovary syndrome, menopause, going through fertility treatment, the whole spectrum. And so See Her Thrive was born. And yeah, we've been around since about 2019 and work with organisations across the globe to make sure that people who are living with these invisible health conditions that are often stigmatised and not talked about, but can be life-limiting, that we have the support we need because we deserve to thrive at work as well. So that's the story. How I did it? No idea. Winging it.
Well, I can sometimes achieve very good results too. Good ideas start with one person, plans with two, you know. So, Carolyn, one for you. What tips have you got from your counselling with how not to be afraid after having a heart attack? And how do you keep positive? And they say you sound like you've got a great attitude. I tend to agree.
Oh, thank you very much. The best thing that the counsellor told me to do was to not worry about things that are out of your control. So I used to worry about everything and everybody, and now I just think if I'm not responsible for it and I can't control it, I'm not going to worry about it. I had a thing, I can't remember what he called it, where if I went out somewhere, I felt like I was bigger than everyone else and that I was wearing a big badge saying, I've had a heart attack. And that was a kind of PTSD. So, yeah, lots of talking. And it takes a while for you to not worry about it all the time. And we don't worry about it all the time. Although my husband says if he can't hear me in the house, even now, he still comes to look for me. Oh. And if I'm very still in bed, he'll give me a nudge, even after all this time. So it never goes away. But you can't worry about it all the time. You can't. You have to live your life.
Exactly.
Just keep yourself well.
Thank you. To you all, do you think awareness around women's health is improving? And the questioners proffering an idea that there's more misinformation confusing people. What's your thoughts?
I think it's much better than it was. I think they talk about it a lot more on the TV, on programs on the TV than they ever did. But I think there's a long way to go.
Yeah, I agree. I think that's it. The awareness, the campaigns are brilliant. It's on people's agendas. People are talking about it. We're talking about it today. But I still do think we have a very long way to go. And I think there's a lot of people still suffering out there that don't know who they can turn to, who they can speak to, what help they can get, what things they could try. We need to make it the norm that people feel they can go and speak to a GP, or they can go and get that help or have that conversation. It needs to be more normalised.
Yeah,
I agree. Yeah, 100%. We've still got such a long way to go. There's so much research that still needs to be done. We've still got more questions than answers. There are still too many people who are not being seen, not being heard, not being taken seriously. And yeah, just it's great that we're talking about it, and that's really, really positive. And I would encourage everyone, let's keep talking about it, let's keep banging the drum, and that needs to translate into action. We really, I don't want to get too political here, but we need government support. We really need this to come from government level, and right now it's not good enough. It's really not.
Caroline, a couple for you, but how do you now feel post-menopause? And they're also, the second question is thanking you for sharing your story again. And how has your life changed since your heart attack?
Well, sorry, what was the first question? How do you feel now after the menopause?
Yeah.
I'm really well. I am really well. Your life changes because you have to be more aware of yourself, I think. Be more careful with yourself. Try not to get stressed, and just really look after yourself. But I just try and do everything that I did before. I still run around after my grandchildren, and I still, do everything really, but I just have to be aware, and I have to listen to the one thing they said to me when I did my rehab was listen to your body. And if you're having a day where you feel really tired, rest, don't keep going. But Yeah.
Good. And you sound great.
Thank you.
Now, Kirsty, for you, where do you want to go next with your research? What's the end goal?
Great question. I think really the outcomes of this study will partly inform where we go next. I think ideally, I want to try and find out more answers. And I think by the time some of this data has been analysed, we might just have, as Claire says, a whole host of more questions. But really, I think we need to try and find, like I've alluded to, some of those interventions and strategies, try and find something there that can help women. And really just sort of cardiovascular health as a whole, that is my interest. And my PhD was in dietary flavonoids in terms of tea. So there's a side that is quite interested in the more natural therapeutics as much as, drugs, if you like. So yeah, really just trying and push forward and try and improve things for women going through some of these symptoms, really.
Good. Just reflecting on one of the questions from earlier on, this isn't a question, but it is for everyone mentioning menopause at work, asking your HR manager if they have a policy. I think, Claire, you were saying this. We set up a women's group at work with help from the HR director. And one of my objectives was menopause awareness. We now have a policy, risk assessment, free sanitary wear, mandatory training. And they add, for a construction company, it's a huge win for women.
Wow.
Isn't that something?
Really good.
That's brilliant.
Yeah.
More of that.
What's that, Claire? That's victory.
More of that.
Yeah.
Yes. Question for Claire. Is it unlawful to list menopause as a reason for medical retiring a woman from their job?
Is it unlawful? So, is it unlawful to list menopause as a reason for a woman retiring from her job? I absolutely don't know the answer to that.
Well, it is a difficult one to answer, in fairness, as we don't know if it was them retiring or being retired. So let's leave that. Question for Carolyn, just how many times did you attend your GTP for heart-related problems before your heart attack?
3. I went to them 3 times, complaining of chest pains, and yeah, I went 3 times. Just kept going back, but they just kept telling me that I was suffering from anxiety and I needed to learn to relax. That's what they told me.
Okay. Well, listen, everyone, thank you very much for your contributions, Kirsty, Claire, and Carolyn, again, for sharing your own personal story so widely. It is really valued. And thank you at home for watching this edition of Live and Ticking. We hope you've enjoyed hearing from all of our brilliant speakers. Before we wrap up, I'd like to ask you a final poll question, and it's, how would you rate your understanding now of menopause and the heart? And once again, that'll come on your screen. And if you could give an indication from 1 to 5. Thank you. If we haven't managed to answer your question today, then we encourage you to visit our Heart Helpline, where you can contact our dedicated clinical team about your query, or you can visit our Menopause and Heart Disease webpage. All of our incredible research is funded 100% by you, the public. If you've been inspired by the amazing science you've heard today, then all donations to support our life-saving work are very much appreciated. There's a link should you wish to do so at the end of the event. Live and Ticking is a monthly webinar series, and we strive to produce the best events possible for you, our audience. Your feedback and comments are crucial to help plan and develop future events. So we ask if you can complete the survey at the end of this event or through an email you receive in the coming days. This Live and Ticking event was recorded and will be available on our YouTube channel from early November. Our next event will take place on the 25th of October on the topic of pregnancy and the heart. Thank you again for joining us, and goodbye.